So I'd like to call upon Dr. Aishwarya, who is going to take us through managing one of the toughest grade of cataract. Those are soft cataracts. So please take us through pearls of managing a soft cataract.
Thank you, Dr. Tejal. So good afternoon, everyone. It's very nice to see a full hall over here. So I'll talk about why we emphasize on soft cataracts. The problem is that over here, we are looking at more awareness in patients who are presenting early to us. They have problems in driving. That is normally the first problem that they come with, and more expectations because they think that if you can do a cataract surgery, can you please help us from removing the reading glasses? Now, the issue over here is that we have to identify a soft cataract, anticipate a soft cataract when the patient is young. Then you have to talk about having a lens opacification system where you should be able to say that yes, you have cataract, and that is the reason probably at the age of 25 that you are undergoing this problem of not being able to drive properly. And look at something which is known as the DLI score. The DLI score comes on eye trace, and often a lot it has saved us from embarrassments where patients were told that, okay, because of the DLI score which is going towards red, and although it is not showing a lot of changes, this is the reason that you are having difficulty in doing your day-to-day stuff. Now, coming to challenges of soft cataract, we all have encountered fishbowl, we all have encountered PCRs, difficulty in holding nucleus, cheese wiring, and difficulty in rotation. Now, these problems can be understood better if we look at the videos now. So I'll just show you the problems and the solutions. Coming to capsulorhexis, we have a very elastic nature of anterior capsule. And please remember that, like Dr. Venkatesh said, that use a ripping force instead of shearing force. Stain the anterior capsule with trypan blue dye and make a slightly larger capsulorhexis. Why? I'll show you. Because if there is a larger rhexis, you can actually have a good overlapping of the IOL to overlap a 6 mm optic. You can have hydroprolapse. That's one of my favorite techniques to do it. And also it allows for optic capture just in case if you've had a rent. Hydro procedures. We know that the conventional hydrodissection, cortical cleaving hydrodissection, hydrodelineation, and hydro-free dissection, all these 4 techniques should be a part of our armamentarium. No matter what comes, all of us can use all these 4 techniques instead of using only hydrodissection as a part of your armamentarium. The problem of cheese wiring and gelatinous endonucleus attached to the capsule by thick condensations of cortex can be countered with a good cortical cleavage hydrodissection and minimal rotation to avoid cheese wiring, but ensure one good rotation so that you know that you are in the correct plane for doing the surgery. Now look at this particular video. Over here I am doing hydroprolapse of the nucleus. This is my favorite technique because I feel that I can finish off the surgery faster and very safely. Now once the rhexis is done, I ensure a good hydrodissection, and just look at this. The nucleus has just popped out. Although you will be having a slightly shallower AC, but at the same time, once the nucleus is flipped out, and since it is a soft nucleus, you have a lot of space to move around, and you have been able to emulsify the nucleus in a safe zone. Now, when I talk about multiple hydro procedures, just look at this particular video where we are ensuring a good rhexis with a good glow. Good glow and a stable anterior chamber are very, very important for this particular techniques. Now look at this. I've done multiple hydro procedures. I've done basically 2 golden ring reflexes that you can see. This helps me to emulsify faster and also helps me to emulsify in a safer manner, and it also reduces the amount of bulk that I have to remove during my irrigation aspiration. Now coming to nucleus management, we are talking about endocapsular techniques and supracapsular techniques. Like Dr. Nareen mentioned, supracapsular techniques can be slightly tricky. It is better to probably more tend towards endocapsular techniques. For example, modified stop and chop, chip and flip, bowl and snail, and mechanical chop. Now here, when we are looking at modified stop and chop, this video is courtesy Dr. Rohita ma'am. So over here, a central trench is being made, ensuring that you have a very good anterior chamber. the trench has to be end to end, but at the same time making sure that the division happens with the help of your second instrument and the first instrument both. So just go there. The division has happened. And now a quick rotation. And with this, if you can look at the center, just like how we have just spoken about the fiber orientation, getting a good purchase is very important. And once it is done, you can just see this, that the doctor is able to take out the first half easily without even having to go for a direct chop or any other chopping techniques. Now this is a modified stop and chop technique. And over here, even for the other portion, once the rotation is happening, a good rotation and hooking the nucleus by the shoulder, taking it out. So this technique is a very good technique if you like doing stop and chop, and also in different situations where you may have a central nucleus which is very soft but still a little more fibrous peripheral cortex. Now coming to the chip and flip technique, this is again by Dr. Rohita. Just have a look at this. After ensuring the good side ports and a good main port, you can see the cortical cataract is more towards the nasal side of the doctor because the doctor is sitting temporarily. A good rhexis. And then a good hydrodissection. Please remember, if the cortical cataract is away from you, try to do hydrodissection in areas where the cortical cataract is not present, so that you can actually have a good purchase, and at the same time, if at all there is a lot of fibrosis, you can prevent a PCR. Now with this, again, the central nucleus is already taken out. The endonucleus is taken out. It is basically like making a bowl, especially making a bowl. But at the same time, going nasally, just see how the nucleus is actually coming out on its own. But at the same time, the purchase is towards the front, that is towards the nasal side, and then you are able to emulsify the nucleus. Now coming to the bowl and snail method, this is a flax related patient where the flax was already done. Now ensuring the hydrodissection is done at a plane where it becomes easier for us to remove the cortical matter, and also a sheet of cortex has been taken out already with the help of hydrodissection cannula. And then the emulsification can happen at a good pace. Now with this, I think we'll just move on to the mechanical chop technique. Now mechanical chop technique, this video was given to us by Dr. Venkatesh sir. Here what is important is to remember something, that the no phaco power is going to be used when you are about to dissect the nucleus. It's very easy, just go ahead, make a rhexis and go ahead with the hydrodissection cannula. Once make sure that the nucleus's rotation is present. Don't hold the nucleus at any number, like not at 1, 2 or 3, just keep the irrigation on, and then you can simply divide the nucleus with the help of your phaco probe, just as a hook over there to hold the nucleus, that's all. A good hydrodissection over here, and then once a phaco probe is put, I think I cannot emphasize more upon the fact that you have a golden ring reflex every time when we are doing soft cataracts, because that is one of the main things which helps us in doing our surgeries. Just have a look at this. He's just holding it and he's just cracking it into 4 pieces over here. Now this is one of the techniques where we are doing a direct chop.
So what we need to do is, now if at all you're doing mechanical chop, the meaning mechanical chop is we're not using or going to step 2 or step 3. We are doing it under irrigation itself. Yes. Okay. Now what you need to remember is the dialer that you use, the tip should be little long. It should look like a chopper but not a chopper. Okay, the tip should be blunt. Now, the technique, how is, you should take the phaco probe, just impale, you don't need to, I would say either you can do like a stop and chop also, you can just do a small trench and then hold it in that place and do it also, or what you can do is, just place it in the center, right, 45 degrees, you're in the center of the lens. You don't need to press, because if it's soft, then you don't need to use even vacuum also. You can reach the center. You just be in the center, hold, use a 45-degree tip whenever you're doing this, and use a 45 degrees to your right, face it to the right. So it acts like a hand, right? It acts like a hand to push this part away. Now what you need to do with the dialer is, do a long chop, that means keep enough distance from the phaco tip, go deep towards the tip and then slow sideways. Okay, I'll repeat it again. Long, start from far, quick chop towards the tip, but it should be deep, and then slow sideways. Slow means really slow, just wait, separate, slow, separate, wait, like that. So this, 100% you will get a chop, even the softest of the cataracts. So that you need to remember. See, there are many ways to skin the cat. I don't know why that phrase came, why someone has such a bad thing with cats, but the whole point is you need to stick to one technique, and I mean, you can try everything, but stick to one and repeat, repeat, repeat. And that's when you become very good at that technique. But every time you touch the lens, you're trying some new stuff, then you'll end up not perfecting anything. So that you need to remember. I personally always do a mechanical chop. The second what I do is, I think maybe you can.
Yes, I have this. So this is also one of the techniques that we can use. That is the rapid technique, where you can have a rotation, alignment and impaling, placement of the nucleus, and impaling and devouring the nucleus. Now this is one of the techniques where if I have a slightly harder cataract, that is around grade 1 with NS1 PSC, and that is where we would like to go ahead and do the chopping over here, like a single chop, impale in the center, and then just align it, place it, and impale the nucleus over here and devour the nucleus. Now I'll talk about here on the small pupil technique.
I think you can skip the small pupil.
Yes,
go to
sir.
the next. Yeah.
Posterior polar catney. And this is also a soft mature cataract over here. And over here, the looks can be deceptive. You have a mature cataract with no glow and sometimes can be a soft mature, and difficulty in attaining good chops due to cheese wiring. But over here, what's important is that slowly you have to be very careful in dealing with the soft cataract while you are using a mature cataract. Now over here we have epinucleus management, where you can have a carousel technique, a zero power vacuum, low vacuum technique, and a viscoprolapse technique, where it is important to have inadherent hydrodelineation which may leave thick epinuclear plate behind, where taking out the nucleus becomes easier if you can chop in the center and then use the side areas to take out the nucleus.
Can you go to the last?
Yes, sir. So this is getting stuck here.
No, that's fine. Don't worry.
So we can talk about the smile technique, sir?
No, that's fine. I think
Yes, sir.
maybe if time
I
permits
have-
at the
yes.
end, I can
Yes,
show
sir,
it.
you'll
I'll
show it, sir.
Yeah, that's
Okay.
okay. Don't worry. It's done, right?
Yeah. So we have this 10 pearls in soft cataract. I think we will probably go ahead with this 4 things to remember: that a good sized capsulorhexis, a good cortical cleavage hydrodissection, a minimal rotation to avoid cheese wiring, lower settings in terms of power, AFR and vacuum. Then remember that no size fits all. We should be familiar with a lot of things and a lot of techniques to apply the one which fits the case best. Use adequate protection of endothelium. And for epinucleus removal, the carousel technique and viscoprolapse can be tried. And then with cortex removal can be challenging due to sticky nature of soft cataract. Along with that, early onset PCO is frequent in younger patients, so that is why meticulous capsular bag cleaning should be done. And at the same time, flax, if available, ensures a safer surgery with good visual outcomes. Thank you.
Perfect. So one point I wanted to bring about is, now we have a tendency that, okay, it's a soft cataract, let me reduce my vacuum and flow, correct? That's what we get. But why should you do it? Can you actually chop using vacuum and flow in soft? Anyway you can't, then why do you want to manipulate that? Leave it alone, because anyway you're going to do a manual chopping. You're going to only use irrigation and chop. After you're finished chop, if your vacuum and flow is low, what's going to happen is you'll hold, release, then finally there'll be a thin plate. You'll end up going so close, you'll end up with a PCR. So don't do that. So what you need to do is keep the settings high itself, the flow and this, so that if you just touch it, tuck until the piece will come to you, and then you'll finish off the case quickly. And you're operating, it's not that, oh no, the flow is high, that's why I'll get a PCR. No, not really. If by chance, according to your, depends on the capacity of the machine, whatever you feel like it's high enough that the machine's able to compensate, be able to handle without a surge, then use that settings. That's important, because every machine behaves a little differently. You have to make sure there's no surge and then operate. All right? Perfect. Thank you.
Thank you so